Right. Oh, thank you very much for the introduction. And also thank you for inviting me to present. It's one of the most prestigious things I've been asked to do, so thank you. What I'm going to talk about is ADHD and comorbid conditions and how we disentangle the two. And listening to the previous speaker, I think it's very interesting how we still have this dilemma about whether ADHD exists in adults or not. And the way I look at it is essentially we look at ADHD as a cluster of symptoms. To some degree, we all have symptoms of ADHD, and I think it becomes important when those symptoms start to interfere with our lives that it's maybe worth doing something about. I'll just share my disclosures and then start off with this particular slide. So when I sit in my adult ADHD clinic, so everybody I see has ADHD, but they all have comorbid conditions, or I should say at least 2/3 of them have comorbid conditions. And when we look at a particularly good Spanish study, they looked at people being diagnosed with ADHD for the first time and worked out whether they had any comorbid conditions, and at least 2/3 had at least one comorbidity. The World Health Organization did a much larger survey of adults with ADHD and found over a half had at least one comorbid condition. And if you can see the other figures there, just under 15% had 3 or more psychiatric conditions. So with ADHD, without a doubt, comorbidity is the rule, not the exception. If we look at it now from a general adult psychiatrist point of view, I'm going to present a couple of studies here. The first one is a large European study that looked at non-psychotic adult psychiatric outpatients. They screened them all for ADHD and found 47% screened positive for ADHD, which is really high. There's all sorts of reasons for that, which we'll go into later. When they looked at those 47% and did a full evaluation using the DIVA is a semi-structured interview, they found that 17.4% actually had DSM-5 ADHD. In a similar study in England, a much smaller one, they found 22% of general psychiatric outpatients had comorbid ADHD. So in other words, when you are sitting in your general psychiatric clinic, you would expect 1/5 of your patients coming through the door to have comorbid ADHD. This is the European study that I mentioned in quite a lot more detail. This is looking at the different psychiatric conditions that we see in general psychiatry. And probably one of the most common conditions we see is depression. And you can see nearly 1/8 of patients with depression have comorbid ADHD. And there's quite a lot of interesting work underway at the moment looking at treatment-resistant depression, where you find that the prevalence of comorbid ADHD is much, much higher. The headline figures here are substance misuse and alcohol abuse, where nearly 1/3 of patients with those conditions have comorbid ADHD. The bipolar figure is really quite striking. So 1 in 10 people with bipolar disorder have comorbid ADHD. There's an American study, which is actually much bigger than the European one, puts that figure at nearly 20%. So a really high proportion of patients with bipolar disorder have comorbid ADHD. And it's interesting that the reverse is also true, that amongst people with ADHD, you expect to see at least 10% with comorbid bipolar disorder. Previous speakers sort of paid attention to DSM and ICD classifications of ADHD, and I just want to draw your attention to the symptoms that we collect in order to make a diagnosis of ADHD in adults. And essentially, you need 5 or more symptoms of inattention, or you need 5 or more symptoms of hyperactivity, impulsivity, or 5 of both. So you can have diagnosis of inattentive ADHD, you can have combined ADHD, or you can have ADHD, which is just hyperactive stroke impulsive. So a whole range of things. But when you look through those symptoms and think about everything we see in our general psychiatric clinics, we can see that an awful lot of our general psychiatric patients have these symptoms, whether or not they've got ADHD. And so let's just go through those in some detail. If we look at ADHD and major depression, what you can see is that there's an awful lot of shared symptoms. So low motivation, problems with concentration, restlessness or agitation, difficulty with sleeping, irritability, memory problems, etc., are symptoms that are common to both depression and ADHD. There are some differences with ADHD, the excessive talkativeness, racing thoughts, impulsivity, you generally don't associate with depression. And I think the biggest key is that with ADHD, the symptoms are there all the time. It's a chronic cause. Whereas with depression, it can come and go, it's episodic. And I don't really think many psychiatrists would have difficulty disentangling ADHD from depression. But of course, the important thing is that often the conditions occur together. And that's where we've got to be really alert to the possibility of ADHD in our depressive patients. What is the link between ADHD and depression? An absolutely massive project, a meta-analysis, genome-wide association study showed that major depressive disorder has the highest positive genetic correlation with ADHD. There's more to it than the genetics. What about life events and negative experiences? If you've got ADHD, this is likely to influence how you process difficult events. And we also know that negative life experiences are more common in ADHD. Emotional dysregulation is recognized now to be a very important symptom in ADHD, although it's not in the research criteria. But that in itself is a risk factor for developing depression. Also, the excessive spontaneous mind wandering that happens in ADHD, this is in relation to dysfunction in the default mode network. The default mode node network is the network that's busy when our minds are wandering. In ADHD, it's very difficult to switch that off, so your mind continues to wander when you should be paying attention to something. And that dysregulation is also thought to increase the risk for developing depression. If we look now at ADHD and bipolar disorder, I think ADHD and hypomanic episodes are almost indistinguishable. The shared symptoms of impulsivity, hyperactivity, inattention, and mood swings are common to both. Clearly, the degree of the symptoms is that much more extreme in your hypomanic or manic episode. When you look at the course of the condition, again, this is what gives us the clue as to what's ADHD and what's bipolar disorder, with bipolar disorder being a very clear episodic course, with ADHD following a more chronic course. If you look at ADHD and bipolar disorder when they occur together, so there's a couple of studies here that compared adults with ADHD with bipolar disorder with adults without ADHD with bipolar disorder. And those who are comorbid for bipolar and ADHD have a younger onset of the bipolar disorder, an earlier onset of the first affective episode, younger onset of first depressive episodes. They tend to have more frequent affective episodes. There's more comorbidity and more interpersonal violence, where bipolar disorder is comorbid with ADHD. So I think that whenever we see a patient who's presenting with bipolar disorder at a very young age, it's highly likely that they will have comorbid ADHD, and we should look for that. In terms of what are the potential underlying mechanisms, Family genetic studies find that ADHD is significantly more prevalent in relatives of individuals with bipolar disorder and vice versa. So in other words, if you have a patient with bipolar disorder, the rates of ADHD in their relatives is much higher than the general population, and vice versa. When I look at my ADHD patients and ask them about family histories of bipolar disorder, it's much higher than one would expect in the general population. Genetic effects seem to account for 64% of the correlation between the two disorders, with variations in calcium channel signaling genes being more associated with ADHD and other disorders, including bipolar. Whether there are shared factors between ADHD and bipolar disorder which can explain this, so far the results have been very inconsistent. What about ADHD and anxiety disorders? Again, a number of shared symptoms: mood swings, restlessness, decreased attention, difficulty concentrating. But one of the main things here is that the inattentive symptoms tend to only occur when an individual is in a period of anxiety, whereas within ADHD, the symptoms again are chronic. It's very interesting when you look at anxiety disorders and ADHD, when you look at the lifetime risk of anxiety in people with ADHD versus those without ADHD, you can see that the lifetime risk of ADHD is significantly higher if you've had ADHD in childhood. The age of onset is much younger if you have ADHD in childhood, and the severity of the anxiety symptoms is higher if you have ADHD comorbidly. The European study that we talked about earlier looked at anxiety disorders in quite a bit of detail. And one of the things that was fascinating was if you have ADHD treated in childhood, you find that the rates of anxiety are significantly lower at 28% than those whose ADHD wasn't treated at 45%. So it does seem that if you can get in early, treat ADHD in childhood, you can really have a positive impact on the development of anxiety. Okay, this is much more tricky, borderline personality disorder and ADHD. Because they both have a chronic course, it's harder to disentangle the two conditions. And the sort of headline symptoms of both conditions, the affective instability and the impulsive behavior, is common to both. But clearly there are differences. The emptiness, the fear of abandonment is so much more associated with borderline personality disorder, as indeed the self-injury. With ADHD, you've got your hyperactivity, your attention deficit that doesn't tend to happen with borderline personality disorder. In terms of what are the potential underlying mechanisms between the two conditions, well, children with ADHD are at an elevated risk for emotional abuse and neglect, with sexual abuse, physical neglect much more common in females with ADHD. An exposure to such traumas may increase the possibility that a child with ADHD will develop borderline personality disorder. There's also a really high correlation between the symptoms of ADHD and borderline personality disorder with respect to the genetics, which demonstrate 49% of the correlation could be explained by additive genetic factors and 51% by unique environmental factors. If we look at the neurobiology, the default mode network, that part of the brain that's active when we're daydreaming, patients with borderline personality disorder have grey matter abnormalities in the default mode network and the frontal limbic circuit compared with controls. And we know in ADHD there's reduced network homogeneity within the default mode network. And so it does appear that there's some commonality there between the ADHD and borderline. Emotional instability is an interesting one. The clinical dysfunctions of top-down regulatory networks can be associated with non-emotional control, like in ADHD, or emotional control, like in borderline personality disorders. And as the networks can be associated with both emotional and non-emotional control, there's this real potential for overlap between the comorbid states. having poor capacity for emotional processing. So what do we do when we have comorbid conditions? How do we treat the ADHD? Do we treat the ADHD? And my view is that we shouldn't be depriving patients of treatment of their ADHD. Not only will it help resolve functional impairments associated with the ADHD, but there's a really high chance that we can make the treatment of their comorbid conditions that bit better if we treat the ADHD. But which condition do we treat first? Essentially, go for the most severe disorder first. And this is particularly important when we have somebody who has comorbid psychosis or comorbid bipolar disorder. If those conditions aren't treated first and we introduce stimulants, we will definitely precipitate relapse. So that's really important. Never treat ADHD in the absence of treated psychosis or treated bipolar disorder. So if the anxiety and depression your patient may have is relatively mild compared to the ADHD, treat the ADHD first. And one of the things that I come across time and time again is how many patients that I see have had failed treatments with SSRIs, for example. When we treat the ADHD, their anxieties and depression seem to disappear as the ADHD is treated, because I think ADHD has such an important role in those two conditions, both in the etiology and for the maintenance. You can combine treatments for ADHD and comorbid disorders. Basically, stimulant medications can be combined with almost anything. I mean, obviously read the small print, but they are safe drugs to combine with other psychotropic drugs. And obviously, when we're deciding on treatment, let's involve our patients. If it's really complex, let's seek advice from a specialist. I mentioned before how important treating ADHD in childhood is with the development of comorbid disorders in adulthood. This is a relatively small study from Norway, where they looked at a number of children with ADHD that were treated in childhood with a number of children who had ADHD that wasn't treated in childhood. And you can see from this graph that the treatment in childhood results in a much lower prevalence of depression or anxiety in adulthood, reduced significantly alcohol problems, mood disorder questionnaires, positive screening is reduced. And overall, when you look at treatment for other psychiatric conditions from ADHD, treatment in childhood for ADHD results in a much, much lower prevalence. Of the other ones, the ones that don't reach statistical significance, the drug problems and the bipolar disorder, I think the bipolar disorder is, it's a very genetic condition, whereas with depression or anxiety, it could be that the presence of the ADHD leads to the development of depression or anxiety. Let me move on, because I think the drug problem ones is a particularly hot topic, with a number of studies, mainly in the States, that looked at treatment of ADHD in childhood, and they compare medicated versus non-medicated subjects with ADHD, and you can see that pharmacotherapy is associated with an 85% reduction in risk for substance misuse. Another study found that substance misuse was much reduced among boys for those who had their ADHD treated as children compared to those who hadn't. And prior treatment with stimulants was associated with subsequent decreased risk for substance use and cigarette smoking in girls. However, this is controversial, and a meta-analysis looked at 15 really good longitudinal studies, and they basically find that treatment of ADHD with stimulant medication neither protects nor increases the risk of later substance misuse. One of the worries has always been, if you treat people with stimulants in childhood, does this increase your risk? Does it lead on to different drug use? And the answer to that is no. And another small study, this is looking at treating adults with ADHD with comorbid substance misuse. This is a population of prisoners, and part of the requirement for release included treatment of their substance use. And of the 60 prisoners they looked at, 30 had treatment for their comorbid ADHD, 30 did not. And of the treated patients, most of those were they were much more likely to have no known substance misuse or follow-up, less likely to need rehabilitation, and more likely to be employed at follow-up. There was no significant difference between mortality between the two groups. This is a fantastic review article by Chang and others, published in 2019, which looks at some of the pharmacoepidemiological studies into ADHD. And essentially what this table shows you, this forest plot, shows you that those studies falling to the left of the dotted line have significantly improved outcomes compared to those on the right side who have worse outcomes. And what you can see here is across the board, injuries and traumas are reduced significantly when ADHD is treated in adulthood. The traffic accidents, again, are reduced, apart from one study in females, but that didn't reach statistical significance. Criminality is reduced, suicidality is reduced, substance use is reduced, depression is reduced. So all of these conditions, if you treat the comorbid ADHD, you find really positive outcomes in the comorbid conditions. The bipolar study, this is a study by Victorin et al., showed what we all would expect. If you treat somebody with a bipolar disorder who isn't on mood stabilizers with a stimulant drug, they relapse. If the person is on a mood stabilizer, then what we find is that not only is the ADHD treated, but the outcome of the mood disorder is better as well. Let's just show you that in a bit more detail. So this is the Victorin et al. Study. Basically, they looked at treatment emergent mania with methylphenidate, and they found that the rate of manic episodes within 3 months of starting in patients with bipolar disorder not taking mood stabilizers had a hazard ratio of 6.7. So a really, really high rate of manic episodes there, high rate of relapse. But for patients on mood stabilizers, the risk was in the other direction with a hazard ratio of just 0.6. And I think this is a really important message. If you've got patients with bipolar disorder who have a young age of onset, frequent episodes, you need to think about ADHD. Not only do you need to think about ADHD, but once you've treated the ADHD, once the person is on a mood stabilizer, then do think about treating the comorbid ADHD, as this will have a positive impact on the outcome for the bipolar disorder. Towards the bottom of that, this same table, psychosis. So if you have psychosis and you decide to treat the ADHD with stimulants, it doesn't seem to have much impact on outcome of the psychosis, neither positive nor negative. This is again quite controversial, because there's always been this worry that if you're treating people with ADHD with stimulant drugs, we all know the dopamine hypothesis in schizophrenia, it would make sense that if we're treating people with stimulants, we may precipitate psychosis. And there was the study quoted there is that there's no overall increase in incidence, but in the New England Journal of Medicine in the same year, in 2019, 3 years later, they looked at adolescents and young adults with ADHD receiving prescription stimulants and looking for their new onset of psychosis. This occurred in 1 in 660 patients, which was thought to be higher than expected, and they found a particularly higher incidence with amphetamine use rather than methylphenidate. Shortly after that article was published, Cortese published a response, and this is really very important, that the study didn't control for persons who were of low vulnerability for developing psychosis. In other words, the psychosis would rarely develop even if exposed to stimulants, versus those with high vulnerability, where the psychosis is likely to be precipitated by stimulants or even no exposure to stimulants. So I think, again, the message is if you have got somebody with psychosis, treat the psychosis first and then think about starting the treatment for the ADHD. One of the worrying things, and this has happened to me, I had a young woman who had schizoaffective disorder. She was on a combination of olanzapine and also Depakote, which is a dreadful choice for a young woman. But her psychosis was relatively, well, it was controlled. We started treatment with methylphenidate, and she got really better, much better. Her functioning improved. In fact, she was so much better, she thought she didn't need her antipsychotics anymore. She stopped her antipsychotics, immediately relapsed, and sadly took her own life. So we've got to be absolutely sure that if we're treating people with psychosis or bipolar disorder, not only do they need to be on their mood stabilizers or their antipsychotics, but they need to stay on them. So in summary, ADHD is a highly comorbid condition. It's a frequent comorbidity in patients attending general psychiatric outpatients. So about 1 in 5 of your patients in general psychiatry are likely to have comorbid ADHD. The symptoms of ADHD are very similar to those in other psychiatric conditions. They often share similar etiologies and neurobiology, and ADHD can be safely managed where there are psychiatric comorbidities. And at that point, I will finish. I will stop sharing my slides, and I think